Hey, good morning, everybody. This is Brittany with the Seniors Blue Book, and I am coming to you live this morning with Dr. Constant from Coastal Orthopedics. Good morning.
Good morning, Brittany. Nice to be here.
Thank you so much for being here. We're going to talk about your specialty, which is pain management, but I would love to, for viewers and myself, to get to know you a little bit better. Tell us your history and background and how you came to be with Coastal Orthopedics.
Absolutely. So I've been with Coastal Orthopedics for almost 10 years, but I did my undergraduate studies at the U.S. Naval Academy, served active duty as a Marine Corps officer, then I went to medical school in Tulane, in New Orleans, and then from there went on to an anesthesia residency, and then was chief resident, and then did my pain fellowship, and I did my training there in Boston as part of Harvard Medical School at Brigham and Women's, and also at Beth Israel Deaconess, and then also did some research while I was in medical school at Harvard Medical School. As a side note, when I was younger, I lived on Siesta Key, so I have a tie to the area community and actually went to a small school called Pineview. I went to Pineview when I was actually near Sarasota High. So, trying to get back to Florida was always in our game plan, and so I'm glad that we are back here, and my family and I very much enjoy being here in the community. Obviously, there's been a lot of growth, and there continues to be a lot of growth around here. But I was attracted to pain management because within anesthesia, those are patient encounters, but you don't get to interact as much with the patient. I actually started in general surgery and did 2 years of general surgery before I moved over to anesthesia. And I enjoyed the continuity of care that you get from a surgical specialty. But what I really enjoy about interventional pain management is the fact that I get to use a variety of modalities, ultrasound, fluoroscopy, to bring medicines to bear to discrete areas that really affect change, and there's immediate gratification for the patient. And then selfishly, there's immediate gratification from our end where we get to manifest and see these changes and see people get a better quality of life. So it's a really great, wonderful merriment of skill and knowledge that you can help people with. Being here at Coastal Orthopedics and pain management is actually a lot of fun. When I say a lot of fun, I'm in a very unique group. I think that we are positioned in the entire United States as a unique group. If you look at the qualifications of our physicians, they are truly outstanding. And so I feel very privileged to actually get to be here, to get to work here, and get to interact with the folks that I have. Because what's nice is when you have such truly stellar colleagues, is they get thrown some curveballs or unusual pathologies. They can pick up the phone or text me, and I can weigh in. And you know what? That's a two-way street, and I feel very comfortable being able to look to them sometimes for guidance when we have a difficult circumstance or a collaborative case. And we have all that knowledge and skill under one aegis, the aegis of our own. And so that's really something special that I want the community to understand, that even though we're here in Southwest Florida, that we take care of some very complicated, complex cases that often have been seen in other very well-known parts of the United States, and we treat them successfully here. So I think that's important to understand when you're not in a major metro area, and a lot of our community travels from major metro areas down here, that this is not a medical desert when it comes to either orthopedics or interventional pain. And I take care of patients who have been treated back in the Boston area where I trained, HSS in New York City, Cleveland Clinic, other places. Even I have patients that travel internationally to come see me from Western Europe, Poland, Germany, France, Switzerland. And so I think that the skill set that we collectively bring is very strong, and it's something that I'm very proud of to be part of.
Awesome. I love that. And I've gotten to know through doing these doc talks, Coastal Orthopedics is amazing, and each and every one of you does have such a high level of expertise, and always love learning from you. And so today we're going to talk about your specialty, which is pain management. Can you kind of give us and I know you hit on this a little bit, but can you kind of give us a general overview of that specialty?
So pain management historically has been a discipline of medicine that's been, if you will, shepherded by anesthesiologists. Because if you think about preoperative, operative, postoperative pain management, and then in the context of both chronic or acute, with that skill set and knowledge base, I think anesthesiologists have historically been not only the founding fathers of that specialty of medicine, but have been well positioned to help patients in that moment of need based on our training and our skill set. And so pain management that we do here is more of an interventional pain management. And what does that mean? We take care of a variety of diagnoses, and that means not only spine disorders, and by spine, that's inclusive of both cervical, which is the neck, thoracic, mid-back, and lumbar spine, but also disparate complaints. I also have subspecialty training within headache medicine. And when I was in Boston, was part of what's called the Harvard Headache Institute. So have subspecialty training within that domain. And there's often a direct link between cervical related issues and headaches. And there's also independent headache disorders. And then it gets very complex when there are more than one type of headache presenting at the same time. And so when we talk about pain management, there are a variety of areas that we cover. And there's also peripheral nerve disorder, and joint disorders, things of this nature. And then finally, there are metabolic diseases that cause pain that we also try and help people with treatment for. So the context in understanding of pain management is very complex, and it's not one that lends itself. And thankfully, we're at a period of time now where the stigma and historical reflection of Florida and pain management was one associated with, I think, excessive pharmaceutical distribution. Instead, now it's come back to, hey, this is a respected and useful medical discipline. And when we think about its role, the number one reason that people seek their primary care physician is usually the common cold. Number two is low back pain. And in any given period of time, every American is going to have some episode of low back pain in their both early adult life and in their later adult life. So it's ubiquitous. And so what you want is to make sure that we have a discipline of medicine that's accessible, that's trustworthy, and that is, I think, effective and as you mentioned, technically, I think, equipped to address those problems. On any given day, I see a variety of patients for either broken back, so I treat vertebral compression fractures, sacral insufficiency fractures, and so there are people who have emergent pain complaints, and there are patients who have chronic pain complaints, and then there are the in-between, the acute on chronic. And so there's a wide range of diagnoses or a wide range of problems that we treat that vary in their acuity. We're not an urgent care, so obviously if somebody has debilitating pain, that deserves and should rightfully be treated and evaluated first to either an emergency department or an urgent care facility. But people who end up with a pinched nerve in their neck, their lumbar spine, who have what's called a radiculopathy, that shooting pain down the leg, those are things that we routinely see and treat here. I even treat, I've had patients who are parturients or pregnant patients. And so we find that there are complexities when we get surges of progesterone that allow ligament laxity. And so people end up with sacroiliitis. So there is no one-size-fits-all vanilla flavored patient. It is a wide range of things that you need to consider. And so that keeps this job both interesting, fun, and most importantly, challenging. And so you've got to stay current with your knowledge, current with your treatment, and current with the things that you have to offer.
Absolutely. And you mentioned one which is really common, which is lower back pain. Can you tell us some of the causes of lower back pain and how is that diagnosed?
So low back pain becomes kind of like, I think, the equivalent of irritable bowel syndrome for the GI doc. You know, low back pain is a trash can term, but we've all had it, myself included. And you want to be discreet, deliberate, and decisive in your approach to this, because patients and self-treating clinicians, which you don't want, but they look at this as, oh, I think I know what the problem is. Instead, you need to take a step back and consider, hey, it's multifunctional, because low back pain can be a myriad of things that all have a similar referral pattern. And so it's not a discrete one, but it's a combination of things that overlap that present. And so it could be a musculoskeletal disorder like a spasm. It could be a sore joint that then begets the spasm, or it could be a sore joint with a spasm that then pinches the nerve. And so now, I've just explained three different iterations of the same problem that could be discretely one, two, or three different etiologies or sources. So low back pain, I think when patients experience it, the most important thing to do is to assess where is it, how often do you get it? And are there any precipitating or aggravating activities that you perform that you become more aware of it? Because if you self-analyze and kind of remember those details, it makes cracking that nut and coming up with the correct diagnosis much easier for your treating physician. Because and I sympathize and empathize with patients. When you're in pain, you're in pain. So there's these discrete details you often overlook because you're just like, hey, I'm uncomfortable. Or we're a very driven society. It's very busy and you don't have time to pay attention to the pain. But it's very important that we try to understand, hey, what are the associated symptoms? When do I get them? And what am I doing when I'm experiencing them? So that can be articulated, and then together we can dialogue to come up with a plan. Oftentimes, low back pain, as I mentioned, can be transitory and will 80% of the time get better within 8 weeks. In those patients where it's not resolving, not getting better, diagnostic imaging becomes very important. And by diagnostic imaging, I think x-rays are fundamentally first an easy step, but more importantly, getting a more detailed look through something like an MRI, magnetic resonance imaging, which is not radiation, but actually looks at the soft tissue structures like nerve, ligament, and disc. And that helps us understand this a great deal. As a fallback, sometimes we might even use computed tomography, and that is CT, or what people call a CAT scan, and that we use for folks who either have a pacemaker or an AICD, implantable cardiac defibrillator. In those patients where an MRI is precluded, this is another modality that's helpful. And so from there, we can come up with the correct diagnosis. But I wanted to share, Brittany, that the most important part of what we do is really the history. And when we're trying to break things down, history is 80% of what we do, and that's the dialogue. And then I would say physical exam is probably the next 18%. And the last 2% really is the MRI, the CT, and the x-rays. Because between that history and physical exam, we should be able to nail down this diagnosis very well. And we're using these diagnostic modalities to really rule out anything else that I have to be concerned about or we have to be concerned about, versus we're left kind of awash without a clear understanding. Rarely we might ask patients to get another kind of diagnostic study called an EMG. E is in electromyography, and that's a nerve conduction study. And that's kind of the icing on the cake when we're looking at all these things. But if we have a good history, good physical exam, the MRI is usually kind of like the icing on the cake that lets us conclude and come up with a decisive plan to get patients feeling better.
Awesome. And when it comes to somebody, let's say, that has that chronic back pain, what are some of the treatment options that you provide through Coastal Orthopedics?
So chronic back pain, it's going to depend on age and what kind of back pain. But when patients present with chronic back pain, that could be in a younger patient. And by younger, I mean 20s, 30s, 40s, 50s, where it's a discogenic etiology. So they have a herniated disc or a desiccated disc, and that disc becomes, I use the term cranky. It becomes uncomfortable and painful. And so for those patients, typically I think that modification of activity and exercise habits with good physical therapy instruction, which we have here, is really a mainstay therapy. And that is, making sure that they remain active. Swimming is wonderful, non-impact exercise, so avoidance of ellipticals, avoidance of running on pavement, but still maintaining activity is very critical. Things that I offer those patients interventionally usually are things such as an epidural, which can be effective for that discogenic pain. In folks that have chronic low back pain associated more with an arthritic condition, such as facet arthritis, and facet is F-A-C-E-T, and those are the two joints that actually join a vertebral body. And that joint is just like a hip, a knee. Over time, it becomes arthritic. We have a different approach, a different therapy to offer. Unlike a knee or a hip, we can inject that, and if it fails, then we ultimately might do an arthroplasty, replace that joint. We don't replace these small joints of the spine, these facet joints. Instead, we do a diagnostic injection of a local anesthetic, and if that provides a brief respite or improvement of pain, then that validates that's the pain generator. And then afterward, we can come back on a separate occasion and apply heat through a needle tip. That heat stuns the nerve to that arthritic joint, and it does so long-term, 6 months to a year. I've even had 18 or 24 months of relief. And that procedure is called a rhizotomy. That's R-H-I-Z-O-T-O-M-Y. That's a mainstay therapy that gets performed in Western Europe, United Kingdom, North America, Australia, New Zealand. And I do that for other locations, even for the knee. I do that for the shoulder and some for other unusual types of pain conditions. But for your question regarding low back pain, those are like mainstay therapies. Occasionally, patients might have a low back pain, and you find out that, as we were discussing earlier, it's a combination of things. They might have some associated sacroiliitis, and that's the joint that joins your pelvis and your sacrum together. It's more common in ladies than men, but very amenable to an intra-articular injection if needed. And it's also very amenable to some good stretching and PT. And then lastly, I think that we underscore the value sometimes of what a good stretch and what a good massage can do for patients. A lot of these are musculoskeletal disorders, and where I trained in Boston, we actually had on-site acupuncture and things of that nature. And I think that patients sometimes think of massage as being a gratuitous, element within their life. And it's not a gratuitous element. It's actually therapeutic. And so if you can get with a good masseuse, particularly if you have like a piriformis syndrome or sacroiliitis, it can make a world of difference. It can be as equally effective, in my opinion, as some of the injections that we do. And it's far more pleasant to have that done to you than sometimes coming in to have a medical procedure performed. And so I think if we think about having a problem, attacking it from more than one angle at the same time, I find that patients tend to do better, progress better, and have a better outcome than if we rely on one modality by itself.
Absolutely. That's amazing. Thank you so much for sharing that information. And I like to, as we kind of close out, just ask if there's one piece of maybe even simple is the word, simple advice that you could offer to people that are watching that are dealing with a lot of pain right now, besides calling you, of course, and scheduling a consultation. What would you say to those patients? What's some advice you can offer for some maybe simplified pain management?
So I think it's simplified pain management, and I know that our audience is the blue book that we mentioned, but we're doing a lot more from home that we weren't doing before. And so we're now restricted to operating in an environment that is artificial, because before we either had an office for which we performed our clerical task. And so, it's interesting that in this new era that we're all existing in, this COVID era, that ergonomic related kind of low back pain, ergonomic related neck pain is actually presenting more frequently. And so to make sure, and it sounds so simple, but just to assess what is your environment at home. How are you looking at the screen? Because, ultimately people either are using iPads, Kindles, laptops, whatever. And people end up with their legs on a coffee table, slouched on a couch, neck down, or some permutation of what I just described. And it's really self-defeating. It's deleterious. It's not helpful. So instead, if you're committed to trying to work from home or do these other things, is trying to optimize your home environment. If you have encyclopedias, put the laptop up there. Standing desk, stand at the bar or at the counter that you have in the kitchen, alternate your position. Those are the simple things that I would say in this new era that we're in. For those folks who aren't forced to work from home, but are, like you had indicated, suffering with chronic low back pain, this sounds overly simple and it can be sometimes disappointing, but just listening to your body is so important. So stretching in the morning is critical, I think, especially as we age. It really is. Once you're in your 50s, you should have some sort of regimen of stretching. Avoidance of lifting away from the body. It sounds easy, but everybody goes to the grocery store. Everybody gets stuck with a grocery bag from Publix or somewhere else that's too heavy, and they're reaching across their trunk to get it. And you know what? Be careful as you're pulling things out to make sure that they're close to your core, and you laterally rotate it close to your core, not arms extended. I promise, that's an easy way that we see injuries that could have been avoided, and it's simple from just simple everyday things. So I'll conclude with that. There's a lot more I know we could discuss, but I appreciate you taking the time to speak with me this morning.
Awesome. Thank you so much. And I know just from me personally working from home and a lot of us that are watching, that's perfect advice. So I had just been looking into stand-up desks recently, and I think that that's, like you said, changing positions is a simple but a great modified thing. So I want to thank you so much, Dr. Constant, for being here with us today and sharing all of your knowledge And I'll have your phone number and information, of course, here at the bottom of the screen, as well as before and after the video, so people can reach out to you so that they can, inquire about pain management through Coastal Orthopedics. So thank you again, Dr. Constant.
Thank you.
Have a wonderful day.